Hello, everyone. My name is Tom Leffencheck, and today I will be presenting my evidence-based practice presentation on the prevention of hospital-acquired pressure injuries with early mobilization on med-surg units. The primary problem that this EBP project will be exploring is the prevention of hospital-acquired pressure injuries within the elderly population of patients admitted to medical, surgical, or med-surg units through early out-of-bed mobilization. Throughout the presentation, we will be covering multiple topics that give a background on the primary problem. Topics such as the current standard of care, that's turning and repositioning a patient in bed every 2 hours, will be explored for its impact on care and its application to current patient care practices. The primary at-risk population used for this EBP project is the elderly, as they have the highest risk for development of hospital-acquired pressure injuries, which will be researched in depth further. The active static turning and repositioning of a patient every 2 hours while they are in bed compared to the active early out-of-bed mobility will be explored for which act is potentially more effective in the prevention of these hospital-acquired pressure injuries while patients are admitted to the med-surg units. We will look at how the active early mobilization out-of-bed protocols affect the rates of hospital-acquired pressure injuries in the elderly population that they are affected most by these injuries. These new protocols will be driven by nursing, and we will explore what effects nursing plays on the implementation and success of these early mobilization protocols leading to the prevention of these hospital-acquired injuries. The PICOT question I've chosen for this EBP project is the following. In elderly patients age 65 and above with limited mobility, a Braden scale score of less than or equal to 16, admitted to med-surg units, does the implementation of an early out-of-bed mobilization protocol led by nursing compared to the current standard of turning and repositioning every 2 hours reduce the incidences of hospital-acquired pressure injuries within the first 10 days of their admission to the hospital? Breaking down this PICOT question, the population I wanted to focus on for this question was the elderly population, age 65 and above, with a low Braden scale score. As mentioned on previous slides, this population of patients are at the highest risk for developing pressure injuries while admitted to inpatient med-surg units. The Braden scale is a standardized evidence-based assessment tool used to help determine a patient's risk for development of pressure injuries, where a lower number indicates a higher risk for development of those pressure injuries. Using the Braden scale as a measurement tool focuses the patient population among the highest risk for development of pressure injuries in the med-surg setting. The primary intervention for this PICOT question is the early mobilization out of bed led by the nursing team for the hospitalized patient population on med-surg units. Throughout research on this topic, early out of bed mobilization is shown to have a significant negating impact on the development of hospital-acquired pressure injuries, which will be shown later. Comparison for this question is taking the intervention of early out of bed mobilization, comparing it to the current standard that is turning and repositioning every 2 hours led by nursing. The overall goal for this comparison is to compare the historical standard to a new developmental approach of patient care. Our outcome will be focusing on the prevention of hospital-acquired pressure injuries while a patient is admitted to the hospital in their first 10 days of their admission. Studies have shown that patients who have developed pressure injuries during their stay in the hospital on med-surg units are within the first 10 to 14 days of admission. Throughout researching this time frame, studies looking specifically at med-surg units primarily focused on this specific time frame. The search methodologies used for this EBP project were through medical databases and search engines such as PubMed, Medline, Cinehall, and the Cochrane Library. For my preliminary research, I utilized PubMed and Medline, as I previously found success applying these search engines to locate and fit within my search parameters. Next, I utilized Cinehall, which allowed me to apply additional filters to my search strings, giving me a more focused group of articles, even with a wider range of results. Lastly, I was able to incorporate the Cochrane Library search. This allowed me to search through articles by types while simultaneously including many articles from different outlets that helped prevent against duplicates. Using different keywords and synonyms based on the specific category I was searching, I created specific search strings for each category with the Boolean operators and as well as or to give myself the widest search margin possible. Utilize tools such as the Prisma flow diagram and CASP guidelines to help narrow the results of what I found. Through the Prisma flow diagram, as well as the use of specific inclusion and exclusion criteria, 520 total records were screened. Excluding articles through reading titles, abstracts, and finally full articles, I was left with a total of 5 articles related to the topic of prevention of hospital-acquired pressure injuries. The CASP guidelines helped track the study design as well as the level of evidence for each individual article that I used for this EBP project. The inclusion and exclusion criteria focus on specific points such as the inclusion of peer-reviewed journals and a focus on med-surg-only articles. For the exclusion, excluding articles on patients outside the range of the PICOT questions such as pediatric and maternity patients or critical care or ICU patients, and focusing on those articles that focus solely on wound care as well were excluded. Through the different search methodologies, key findings were made showing that turning and repositioning of patients every 2 hours was a, quote, low-value practice. An expert article explained the practice of turning and repositioning every 2 hours is based simply on tradition compared to any factual data such as a randomized control trial. The article goes on to explain the importance of individualized risk assessments for patients that are at a high risk for pressure injuries. The idea of individualized risk assessments is the building block for one of the primary recommendations we will see later. Evaluating articles further, evidence with a level 1 rating from the CASP guidelines indicated no statistical significance between using static and turning and repositioning of patients between being turned in bed every 2, 3, or 4 hours. In fact, studies showed that shifting to a nursing-driven pressure injury prevention program of active early out-of-bed mobilization reduced the incidences of hospital-acquired pressure injuries from 3.2% down to 0.9% when done within the first 10 days of admission. These findings all correlate with one another, explaining the little value of static and turning and repositioning in bed compared to the larger impact of active out-of-bed mobilization has. These nursing-driven protocols can only be effective with a nursing staff that has a proper nurse-to-patient ratio, as level 5 evidence collected during the search indicated that the higher the nurse-patient ratio, the more instances of, quote, miscare occurred. These episodes of miscare typically coincided with increased hospital-acquired pressure injury occurrences, as turning and repositioning and out-of-bed mobilization are found to be primary nursing care acts that aren't done due to not being a, quote, priority. Research showed that early intervention of mobility within the first 10-day critical window of admission to the hospital was the most predictive factor of maintaining and preserving a patient's skin integrity while they're admitted to the med-surg unit. With multiple study designs as well as levels of evidence collected from different sources throughout the findings process, this established a base to make recommendations to improve upon the instances of hospital-acquired pressure injuries seen in the med-surg setting. First primary recommendation for this PI-COT question would be installing a safe nurse-patient ratio, as evidence shows that on a med-surg unit, a 1 nurse to 4 patient ratio showed more effective adherence to new policies and protocols being established on the med-surg unit compared to the previous uncapped nurse-patient ratios. Providing the nursing staff with a safe assignment on a daily basis can allow them to follow recommendations to have the best chance for adherence to new recommendations. With a safe nurse-patient ratio established, the next primary recommendation for this PI-COT question would be the development of an individualized early mobilization protocol for each patient driven by nursing within the first 48 hours of admission to the unit. The protocol would move away from the static prevention as mentioned earlier and give the nursing staff an individualized patient care plan for mobilization. This individualization would help adherence as each patient has a personalized care plan based on their Braden scale score and physical ability, allowing nursing staff autonomy in their care for the patient. Another recommendation would be the digital integration of an upgraded electronic health record or an EHR program, such as the Nurse-Driven Pressure Injury Prevention Program, as mentioned earlier. Updating the EHR program to trigger when a patient has a particular Braden scale score, such as less than 16 based on our PI-COT question, provides nursing with a plan of care that promotes early mobility for every at-risk patient automatically. This update will help nursing staff by giving them those automatic prompts for reminding and documenting these individualized plans, again, increasing chances for adherence to the new program. The final recommendation would be encouraging education of the nursing staff on the implementation practices of the early mobility schedule and the use of this updated EHR system. Educating the staff on the upgraded nursing practices and EHR system has been shown to have a positive correlation between adherence to the new program and success of patient care. Ensuring that staff understands this is to be done for every at-risk elderly patient within the first 10 days of admission, no matter what their skin integrity status or diagnosis is critical to the success of the education. When considering implementation of these recommendations, it's important that we remember the factors that could either help or hinder the success of the recommendations for the patient population that they're aimed to help. In order to help the success of these implementation strategies, 3 primary facilitators for success have been established. The first facilitator for success would be the nursing staff buy-in of the decrease in nurse-patient ratios, as well as the new protocols of early out-of-bed mobilization compared to the turning and repositioning. Ensuring that nursing staff have a deep understanding of their increased autonomy with the new protocols and programs in place. Change for nursing staff in the way that they take care of patients can be difficult, but with the proper education and implementation, showing staff the decreased rates in hospital-acquired pressure injuries with the implementation of new protocols from previous studies can be used as an internal motivator for the staff. The next facilitator would be the utilization of an already existing EHR system for digital integration of upgraded electronic health recording programs. Utilizing the already existing EHR system at hospitals would allow familiarity for these nurses when implementing a new system. This familiarity would allow for an easier transition for the nursing staff to learn the updated program, leading to a faster implementation as well as adherence of these new protocols. With nursing staff being bought into change and updated EHR systems, the final facilitator would be the establishment of clear individualized patient movement protocols. Establishing early movement protocols based on the brain scale score for each patient gives the nursing staff clear plans of care that can be standardized for easy implementation. The goal of this movement protocols is to ensure that every patient who meets the criteria is screened and mobilized when the system is triggered. The primary barrier for these recommendations and implementation strategies would be an overall institutional cultural shift in patient care. The current and historical standard of care across all hospital settings in the United States is the turning and repositioning of patients every 2 hours while they are in bed. Instituting a change that directly affects this historical precedent is going to be a major challenge for nursing staff on the units. Implementation of these new protocols and systems can be an all-around consuming process for the nursing staff, as it is changing the fundamental way that they currently do their job. Strategic implementation above recommends the unit deploy the updated ratios first for staffing to get used to their new workflow style. Then, enacting the mobilization protocols and EHR systems would help ease the culture shift to new protocols in the new system. In time, the cultural shift and patient care outcomes can have more success. With the implementation of these new protocols, additional challenges of mobilizing elderly patients is a barrier as well. Attempting to establish sometimes new movement protocols with a patient population that already has concerns for decreased mobility even before being admitted to the hospital can be challenging. Utilization of new technology and different movement exercises can help ensure that every patient who is at risk for development of hospital-acquired pressure injuries is mobilized out of bed, even if before coming to the hospital it was not their baseline. In conclusion, this project aimed to show the correlation between prevention of hospital-acquired pressure injuries in elderly patients admitted to med-surg units and early out-of-bed mobilization. Answering this PICOT question through research would be a resounding yes, as early out-of-bed movement protocols does in fact seem to help prevent against hospital-acquired pressure injuries. Throughout the research process, ensuring that new early mobility protocols were driven by nursing and standardizing the nurse-patient ratios were seen to be immediate impactful upgrades to the current nursing care system of turning and repositioning every 2 hours. Upgrading the EHR system, tools and systems, while educating nursing staff on the importance of adherence to new protocols were both also shown to be effective changes to help prevent against hospital-acquired pressure injuries in this population of patients. Finally, my references sheet. Thank you so much, and let me know if you have any questions.